30 minutes, I believe, this talk.
1 hour.
1 hour?
Yeah.
Oh, we're not going to talk for an hour. We're going to catch up on some time here.
Yeah, that's fine.
It's hard to
Absolutely.
talk for that long about surgery. But here's a list of the surgical options for dry eye disease. And we start with very simple punctal cautery, which is one of my favorite things to do. Superficial keratectomy, PTK, amniotic membrane transplantation, conjunctival surgery, lid surgery, and then ocular surface transplantation, and finally keratoprosthesis. So let's start with the very simple stuff, and that's punctal cautery. Is punctal cautery within the realm of the optometric scope of practice here in Minnesota? Not, okay. It's a simple thing, and there's no reason why it shouldn't be, but a lot of patients who have dry eye disease benefit from punctal plugs. I like punctal plugs, but I find that very commonly the punctal plugs become irritating and then the plugs are rubbing against the ocular surface, and sometimes you'll stain them with lissamine green or rose bengal and you'll see actually staining right above the punctal plugs where they're a problem. You can always use indwelling punctal plugs, but they last for a couple months and they have to be replaced constantly. Punctal cautery for a patient with severe dry eye is a very good idea. I almost never do punctal cautery unless the patient has already tried a punctal plug first. Because you don't want to put a plug in someone's, a cautery in someone's eye and then have them tearing incessantly. So you want to give them a therapeutic trial. I generally reserve for people with Sjogren's syndrome, Schirmer's of less than 5, but it's so comfortable for the patient afterwards. It's a permanent treatment. You just take a handheld cautery, you squeeze the end of the cautery tips, you put it into the patient's lid margin. I will sometimes inject it with lidocaine, but very commonly I just use lidocaine gel in the office. I'll let the lidocaine gel sit for about 5 minutes, let it soak into the punctum, and I just basically just insert it in and do it there. And I tell the patient it's going to smell a little bit like barbecue for a few minutes afterwards, and yeah, it has that little odor of burning flesh so that they're not alarmed by it. And then it really is a very simple 30-second procedure that really helps patients a lot. Tarsorrhaphies. Patients who have poor lid closure have very significant dry eye, and very often it's a concomitant disease where their lid not closing exacerbates an underlying dry eye condition. It can cause persistent epithelial defects. It's very commonly associated with neurotrophic disease. Very common to see this after herpes zoster, herpes simplex, aqueous deficiency tear film, evaporative dry eye, and herpes zoster in particular is probably the most difficult disease we manage on a routine basis. And these anesthetic corneas with neovascularization are just horrible for corneal transplantation. They have very low probability of graft survival. So very commonly I'll do tarsorrhaphies on these patients early on to prevent the eyes from drying out and from perforating. And it's really very helpful. And a little treatment that I thought of a couple years back, this happened because a patient came to my office who had put her artificial tear in, and it was absolutely remarkable how the artificial tear bottle looked exactly like the glue that they use for their nails. And she put it in and her lids were completely closed, and she was absolutely petrified. And I tried everything to get it, I couldn't get it open. Eventually what I did is just cut off the lashes and the lids opened up. And from that experience I said, well, if this can happen accidentally, let's do it purposefully too. So I started doing cyanoacrylate temporary tarsorrhaphies to manage epithelial defects. This is one of the first papers I wrote a long time ago. And I just apply glue to the lower lids. And for a Friday afternoon emergency where the patient comes into the office, or say if I'm in a hospital and I'm going to go to the ICU and a patient's not closing their eye and the eye's drying out, just a little glue to the lower lid, close their eyes, just a 30-second procedure, and the lid will stay closed for about a week. You don't want to get anything into the eye because it's irritating, but along the lashes it works really well. If they don't have lashes, you can do it lid to lid, but it's best to apply it to lashes, and it really works well. And I find it very helpful for patients who have exposure keratitis and dry eye and won't submit to a surgical tarsorrhaphy because they think it's going to be disfiguring. And what I'll do is I just close the lids just a little bit with a glue tarsorrhaphy, and they get to walk around for a week or two, see what the experience is like, and then they come back and say, yeah, I'm ready to go for a surgical tarsorrhaphy and do something more permanent. Anterior stromal puncture. This is the my favorite treatment for recurrent erosions, mostly due to trauma. There are two different forms of recurrent erosion. There's a recurrent erosion that occurs due to map dot fingerprint dystrophy, where you have redundant basement membranes and they slough off. I don't use it for that. For that, you need to do a surgical debridement of the epithelium and remove all the redundant basement membranes. But for patients who have trauma, and it's usually organic trauma. The most common organic trauma is like a 1 or 2 year old's finger. So it's very common in women who are holding their child and the finger just gets mom right in the eye. It happens all the time. And they come in and they have the abrasion, and I warn them that maybe a 10% chance they'll have recurrent erosions. And you can also see it with paper cuts, tree branch injuries, fingernails, as I mentioned before. And it's almost always due to organic trauma. And the management for this is really very simple. Can you just roll the video down below, please? Is that running? Yeah. The management is really very similar, very simple. I put some topical anesthetic in the eye. I take a 25 gauge needle. You can actually bend the needle and use it, or just go straight in. I just create 50, 100 little spots there, and these act like little welds. And what happens is the epithelium will grow into these little incisions into the cornea and create an adhesion that prevents erosions from occurring. And you almost never see recurrent erosions repeat themselves around a anterior stromal puncture, although you will see it on the periphery. So sometimes I need to extend it to the periphery a little bit, but it almost never occurs again in exactly the same place. And a very simple treatment. Kind of fun to do also. It's kind of like a video game. Superficial keratectomy, and we're rolling that video. Sometimes patients who have dry eye will have corneal scar will develop. Very commonly associated with dry eye, by the way, is something called Salzmann's nodules. Have you all seen Salzmann's nodules? They occur very commonly in patients with dry eye, and a lot of times it occurs due to nocturnal lagophthalmos, where their eyes are a little bit open during the nighttime, and they develop these scarring patterns. And Hank and I gave Hank so much credit for my career, have published a couple of papers on this. And basically, you look at the location of the Salzmann's nodules, and you can find out a lot about the patient's sleep patterns. When you see a superior pattern like this, it means that the patient has a poor Bell's phenomenon. The eyes will actually rotate down. About 5% of patients will have a reverse Bell's phenomenon and they'll rotate down. Most people have a Bell's where the eye closes and the lid goes up. So most people have actually an inferior Salzmann's nodule. And what I do in these patients, I talk to them about lid hygiene, treating the lid margin, managing their dry eye, using ointment at night because the ointment will manage them. Sometimes people who have very significant problems will actually have them tape their eyelids, or sometimes they need to have a surgical treatment as well. Liz mentioned things like floppy eyelid syndrome, very common in floppy eyelid syndrome where their eyes are open all night long, and look for that, but it's such a common disease. And you basically just take a Bard Parker, you scrape away the epithelium, you don't cut the stroma. Salzmann's nodules are always like a piece of gum that's stuck on the bottom of a desk, and it's just sitting there stuck in, and if you get into the right plane, you can take it off without cutting into the desk. So you don't want to cut into the corneal stroma, you just basically want to demarcate the difference between the epithelial disease and the stromal disease. What causes Salzmann's nodules? Salzmann's nodules are caused by lid margin disease. The staph bacteria in the tear film that sits there all the time falls off the tear film into the cornea, and the cornea absorbs these staph and staph toxins like a sponge, and the particles get absorbed into the cornea, and then the body's immune response responds by creating inflammation that creates a scarring. So in addition to treating the cornea with a lamellar keratectomy, you've got to treat the underlying dry eye and lid margin disease. Otherwise, history is bound to repeat itself. That's the one thing that I've learned with 100% assurance, is that if you don't treat underlying disease, the original cause of the disease will repeat the result time and time again. So you always have to find out why the patient has a problem, and then treat the disease, but also treat the cause of the problem as well. PTK, phototherapeutic keratectomy, for corneal scars is very effective. And the PTK is a very nice treatment. Here's a patient who had some anterior stromal scars, and I'm just doing a PTK of about 50, 60 microns to get through the epithelium. I call this shooting the blue. What you do is you turn off the lights in the laser suite, and the epithelium, just roll that video one more time. Let's go right back to the beginning and show that one more time. We don't need to show the whole thing, but just go right back to the beginning of the video if you can. I'll go back to my slide. Now I'll go forward, and now we can do it again. I turn off the light in the room, and the epithelium will hyperfluoresce. The stroma will not. So you turn off the lights, and you see it's purple like this, you know you're in the epithelium, and you go down all the way till you start seeing the stroma. When you start seeing the stroma, the purple will go away and it'll turn dark, and that means that you've gotten to the stroma, so you know exactly how deep the epithelium is. And then you just do a little peripheral scar removal as well, and it's very nice for very superficial scars. I was one of the original investigators of the excimer laser. I did my first laser in 1988, and the first paper I wrote was on PTK, and what we found in doing PTK with the excimer laser was that it works really nicely for very superficial scars, but once you get down more than about 50 to 60 microns into the stroma, it starts inducing a tremendous hyperopic shift. So a patient with a mild scar with 20/30 vision will be even more unhappy with 20/25 vision, but now it's a +4. So I don't do as many PTKs as I used to for deeper disease. For deeper disease now, I simply do a lamellar keratectomy with a femtosecond laser. So I use my femtosecond laser. I make a flap of about 110 microns, which is 50 microns of epithelium and 60 microns of stroma. I then just take the stroma, I just peel it off, remove it, apply mitomycin for about a minute, and then put a contact lens on it. It's a very effective way for removing corneal scars without the need for creating a hyperopic treatment. Conjunctival resection. This plays a very significant role in dry eye disease, but it's really more of a common surgery for patients who have mimickers of dry eye disease. And really two of the most common diseases that aren't diagnosed but actually give dry eye symptoms are SLK and conjunctival cheilitis. You all know about SLK. SLK, superior limbic keratoconjunctivitis of Theodore. Fred Theodore was one of my teachers. And it involves superior tarsal conjunctival staining, superior bulbar conjunctival staining. They'll sometimes have filaments, and very commonly associated with thyroid disease as well. There are a variety of different treatments for this. Sometimes people recommend using Criday prophylaxis. Sometimes people recommend using steroids. I found that the simplest way of managing this disease with cauterizing the conjunctiva down or simply doing a conjunctival resection works really the best of all the therapies that I've used for this very common disease. And then finally, conjunctival cheilitis. This is a disease where the conjunctiva inferiorly is a little bit redundant, and the patient will have dry eye symptoms. My eyes are irritated, and I ask him a very simple question. Do your eyes feel like you get a little pinch when you blink? And that's the sign of a conjunctival cheilitis. And you can look at them and you'll see that, and you'll very commonly see staining of the bulbar conjunctiva as well. And there's a lot of treatments for this. Sometimes when people remove it and sew it down, I just basically surgically remove it. This is, for me, is about a 1-minute procedure. I inject some lidocaine into the conjunctiva, pick up the conjunctiva and just snip it away, and I'm done in about a minute. It leaves them with a very red, ugly eye for about a week or two. I explain that to them and then manage some steroids, but usually once you treat it, it certainly goes away. This is a really common problem. That's pterygia causing dry eye disease. Now, why did pterygia cause dry eye? Well, first of all, by definition, pterygia are actinic damage due to chronic exposure to wind and sunlight, most importantly. So they have actinic damage, so their goblet cells are damaged, they have dry eye disease. But the problem with pterygia is very commonly the conjunctiva is elevated in that area, and the tear film doesn't flow over that area as well as it should. It's like having a small debris on your windshield, and every time the windshield wiper goes over that, it misses that spot, and that area becomes dry. So there's a couple of reasons for doing pterygia and pinguecular surgery. Number one, if it's in the visual axis. Number two, if it's uncomfortable. Number three, if it's cosmetically a problem. But number four is dry eye disease, and I've managed some very small pingueculas that may not look like they're so significant, that cause a lot of dry eye. So the patient on the bottom right there who has a pterygium in the visual axis, you would all say, yeah, that patient needs to have surgery to have that removed. But a patient with a very focal elevated pinguecula can be even more symptomatic dry eye because the tear film isn't hitting the cornea in that area, and you'll get a Dellin sometimes, you'll get actually frank corneal staining, and you explain to the patient the way we want to treat your dry eye is to remove the pinguecula or pterygia. David, when you do pterygia here in Minnesota, do you do amniotic membrane? Do you do conjunctival transplants? And that's what I do too. I'm not a big believer in amniotic membrane. You want to treat the underlying disease. Sometimes I'll do it, but I like to do conjunctival transplants on these patients. I find it really helpful. So I just want to describe to everyone how you do that.
I usually just take it from under the lid and then rotate it into that spot and then place it in that area. It basically reduces the inflammation there to reduce the fact that it comes back again. So I use it to protect it with the tarsorrhaphy.
Right. And I do exactly the same. I sometimes will rotate it if it's small, but if it's larger, I'll take a freehand conjunctival excision from under the lid where it's been protected. Under the lid, there's no sunlight, obviously. Take a little section there, I remove the pterygium, I just take that area, I transplant it down to the right place, making certain it's right side up. It's really embarrassing to do a pterygia surgery and turn the tissue upside down. It just doesn't work that well. So I always put a little cautery on it to make sure it's the right side up, and then I want to put limbus to limbus so that the stem cells are right on the limbus, and then I'll just apply, I used to sew it in with some 7-0-Vicryl and 10-0-nylon, now I just use tissue glue and glue them down. And again, the patients are really ugly for about a month. But after a month, they work really well. And the recurrence rate in these conjunctival grafts is only about 2 or 3%. If you do primary closure of a pterygium or don't close it at all, the recurrence rate is about 40 or 50%. Some people use a lot mitomycin routinely for pterygia, but again, mitomycin is going to really make dry eye worse. So I avoid that, except in the most significant cases, I try to keep that away. Why don't I use amniotic membrane? Because amniotic membranes do work for the short term, but again, as I said before, the #1 priority for me in managing a disease is treat the underlying condition. Amniotic membrane, treat the symptoms, and I do use them for patients who have pterygia sometimes, and I'll extend them onto the cornea a little bit, but conjunctiva will replace a damaged stem cell with normal stem cells. I use amniotic membranes for a lot of different things. I really do like them. But as a primary closure, I've seen a lot more recurrences in people who use amniotic membranes and use conjunctiva. Now, if they don't have good conjunctiva, it's certainly better than not using it. Conjunctival flaps. Conjunctival flaps are, again, one of those rare conditions that you very rarely do. This is from a paper that I wrote with Hank again a couple of years back on conjunctival flaps. And what we do is we free the conjunctiva. And the conjunctival flap was described originally by Dr. Gunderson about 100 years ago. And Hank is always very proud. He always comes to me, he goes, you know, I learned my conjunctival flaps from Gunderson. It's like saying, like, I learned how to screw in a light bulb by Edison. And you just take the conjunctiva from above, you free it up, and then you debride the epithelium and you pull it over the cornea. Now, why would you do this? This is done in patients who have significant neurotrophic disease that's not going to get better. For mild disease, I like Dompe's new product. But for severe disease where it's not going to get better, mostly herpes zoster, some 5th and 7th nerve palsies where you have had surgery or radiation, severe dry eye, corneal thinning where I think the patient's going to go on to perforation. You pull this conjunctiva over onto the patient, and it looks, again, beefy and red for a period of time. And then after about a month or two, it thins out. And I've had patients actually see 20/40 through these conjunctival flaps and have remarkably good vision. You try to make them very thin. You try not to button hold them. And it's a pretty good surgical procedure. Liz, do you do a lot of conjunctival grafts like this? Not a lot. Not a whole lot. Yeah. Yeah. Yeah, so for example, I have a patient who has a corneal perforation due to an anesthetic cornea, where I know that if I do the transplant and give the patient back, they're going to perforate again because the underlying condition hasn't been treated, you've been made worse. Is I'll do a corneal transplant and I'll do this beautiful transplant, the sutures are all perfect, and then I'll cover it up with conjunctiva so I can't see it. and then let that heal, and then the patients will actually see through the conjunctiva actually pretty well, and the conjunctiva will prevent the recurrence again of the dry eye and the neurotrophic cornea. All right, amniotic transplantation. See, I do use amniotic membranes. I find it very helpful. A lot of people use it routinely for pterygia. It's not my first-line therapy. I use it for patients who have symblepharon. I'll put it into the fornix. I like amniotic membranes for patients with persistent epithelial defects, neurotrophic keratopathy, Salzmann's nodules, and I will, I use a lot of the different products that are out there. I find them all to be very nice, and sometimes you take the amniotic membrane, you just bring it onto the eye, you put it in place, and you can either put a bandaged contact lens on top, or you can use a Procera that has a little ring around it to keep it in place.
Are you just as happy with the dehydrated membranes?
The question is, which membranes? Well, I like them all pretty much. People do make a big case for differences between them. I haven't seen a big difference. I use Catina's products. I use the Procera as well. So I've been pretty happy with all of them pretty much. Liz, David, any preference on amniotic membranes on a certain type? Do you find a difference between them, dehydrated, non-dehydrated?
At least when I'm doing, like, if I do a tarsorrhaphy for a patient with neurotrophic keratitis or bad disease, I'll use the frozen, sew it in, and then I think they last probably longer than the dehydrated. In the office, I think
that's a good pearl. I like that as well. Liz, anything you want to comment on?
So if it's just kind of slowly healing a defect, I like to heal a little quicker. I'll use the dehydrated. But if I know that there's no disease and I need that to be retained, and the patient's kind of neurotrophic, they're not going to feel a lot anyway, I much prefer the Procera.
The frozen. Yeah. Oh, good. So these are all commercially available. They're easy to use and very, very effective. Lid malformations. Liz talked about this a lot, and I think it's really important to look for this. Everyone sees an ectropion. I mean, you see it all the time, but floppy eyelid syndrome gets missed constantly. Floppy eyelid syndrome is extraordinarily common. And again, I'll go back. Hank and I wrote the first paper on floppy eyelid syndrome in keratoconus. This is the patient, actually, who came in with severe keratoconus and floppy eyelid syndrome. We now see it constantly. And this is something we look for. And by the way, if you ever see a patient who has ectasia, whether it be keratoconus or ectasia after LASIK, always check them for floppy eyelid syndrome. I think about 35 to 40% of my patients who have keratoconus or ectasia are iatrogenic. It's them sitting there lying down, and it's one of my favorite conversations. The patient will be sitting there, and I'll examine them, and no one's ever made this diagnosis before, and they've seen a half a dozen different doctors, and I'll look at them, I'll see the floppy eyelid syndrome, I'll see the keratoconus will be on the right eye, the floppy eyelid syndrome will be on the right eye, and I'll look at them and I go, in examining you today, you sleep on your right side, and you sleep with your knuckle or your pillow pressed up against your eye, and they'll kind of look at me and go, how the hell could he possibly know that? And the wife or the boyfriend, whatever's there, will sit and say, yeah, that's exactly what he does. And I say, you say to him, well, I've been watching you. And it's really very pathognomonic. You see it all the time, and change their sleeping habits. And I can't tell you how many people who come in who have dry eye symptoms, patients who have symptoms of dry eye, and they haven't responded, and they've tried everything, and you diagnose a floppy eyelid syndrome, and you say to them for the first time, you know something, you have floppy eyelid syndrome, and the reason you have the floppy eyelid syndrome is because you're sleeping like this, and you're actually turning your lid upside down. And now they understand that they're part of the problem. They've got to treat the disease. So I'll give them ointments at night. I will do everything. But when really bad disease like this, I send them right to my oculoplastic surgeon and have them do a lid tightening procedure. And that's the only thing that really makes these dry eye patients feel more comfortable. Lid imbrication is another disease that it gets misdiagnosed. Actually, it's very difficult to diagnose this. And this is where the upper lid overlies the lower lid. And imbrication is what's described as shingles on a roof, where the shingles kind of overlay each other. And the upper lid overlying the lower lid causes a poor tear film wetting in this area. And this is pathognomonic of the disease, is that you put in lissamine green or rose bengal, and you flip the lid over and you'll see staining of the tarsal conjunctiva where the upper lid overlies the lower lid. There should never be staining on the tarsal conjunctiva. If there's staining on the tarsal conjunctiva, something is wrong, and this is where the lid is overlying the lower lid. And again, this is treated with ointments, and many times it's treated with lid shortening. And this is a paper that Hank and I wrote that described the use of lissamine green and rose bengal for diagnosing the disease. By the way, another good use of lissamine green and rose bengal to diagnose a dry eye product, I don't have a slide on this, but a dry eye mimicker, which you see constantly, is mucus fishing syndrome. You've all seen mucus fishing syndrome, sometimes very hard to diagnose. I love the sound of it, mucus fishing syndrome. Whoever coined that was a great coin. Mucus fishing syndrome of Harden. You pull the lower lid down and you look at the tarsal conjunctiva, and you won't see it with fluorescein, but again, you pick it up with lissamine green and rose bengal, and you see staining of the tarsal conjunctiva inferiorly on the lid, and nothing else causes this type of staining. It's usually nasally, it's very focal. It almost looks like you can almost see their fingerprint. And you look at the patient and you say, you're touching your eyes or something like that, and sometimes they'll deny it, and they'll say, you say to them, you are using your finger to wipe away mucus, or you're taking a tissue and you're curling it up and you're touching your lids with it, or you're using a Q-tip to get in there to get the mucus out. And your dry eye symptoms will never get better unless you stop doing that, because as soon as you touch the lids like that, you're breaking up the mucin layer and creating a lot of stain. And again, it's a great mimicker of dry eye, not a surgical procedure, so it doesn't really count for this lecture, but look for mucus fishing syndrome. Look at the staining again. This is where, again, I find lissamine green and rose bengal to be really very, very helpful. I'm not going to spend too long. I've got a lot of slides on this, and some of these are my slides, some of these are Ed Holland's slides, so kudos to Ed, who's really the world's expert in ocular surface transplantation techniques. And I hear Dick Lindstrom is coming back to be an ocular surface specialist. He's going to be doing all this stuff here in Minnesota, which is really exciting to see Dick is finally going to do something constructive. What's that? What's that? Exactly. He's excited about it. So here's ocular surface transplantation. For people who have stem cell deficiencies, it can be a variety of reasons. Very commonly, they're alkali burns. They can be due to chronic contact lens wear with preservatives. There's a lot of different reasons for them, fire injuries sometimes, and there's a bunch of different ways of managing them. You can take the conjunctiva from one eye to the other. This is what I will do routinely. This is, for me, a routine treatment. People who have a monocular burn, usually alkali burn, you remove all the scar tissue, and then take the tissue from the good eye and transplant it to the bad eye. If it's in both eyes, you can't do that, so then you use a living related conjunctival allograft, and if you can get a donor whose tissue types is close, it's great. If you can't do that, you can do a donor limbal allograft. You can actually take, if you only have limited tissue, you can actually culture that tissue. I don't do that. This is something that Ed does. And then and finally, you can do donor and relative with a cadaver treatment. So let's just go through these really quickly. With a conjunctival limbal autograft, you basically go to the good eye, you take conjunctiva from above and below, you remove the scar tissue from the bad eye, you take that tissue and you sew it into place, or you glue it into place. And again, works really, really well. For patients who have bilateral disease, you can't take the patient's own conjunctiva, so you want to get a living related or a keratoallograft from a deceased tissue, and you can transplant that in a very similar way. And again, the key is that you need to remove the scar tissue first. Let's just roll this video, please. Yeah. So what you want to do is you basically want to remove the scar tissue and then harvest the donor tissue. You want to take some sclera, you want to take some limbal cells, and you want to take a little bit of the conjunctiva as well. and then you just sew it into place. You place a bandaged contact lens over, and that will repopulate the cornea with good epithelium that will allow it to survive. The knee-jerk response by some ophthalmologists, which is completely wrong, is that when you have a patient with a scar like that, is you just do another transplant right through it. And again, if you don't treat the underlying problem, what's going to happen? History is going to repeat itself. It's going to go back right where it was before. So you never take a severe alkali burn and do a transplant without restoring the stem cells. If you don't restore the stem cells, that's not going to work. Now, you restore the stem cells, sometimes the vision will get a lot better on its own, but many times you do that and then you wait about 6 months and then you do a full thickness penetrating keratoplasty or a DALC to replace the cornea here. And very effective, very satisfying for people who have bilateral disease that they see for the first time in years. They very commonly have to be on systemic immunosuppression. I don't have a background in that, so I will send them to a immunologist. Ed does, so you know, if my real tough cases, I send them to him because he's done a year of immunology as well, and I think Dick's going to be doing the same thing here in Minnesota. Living related, again, we're rolling the video. You go to a family member and you balloon up the conjunctiva. You snip away the conjunctiva. You want to make sure again that you have the right side up, that you have the epithelium in the right place. And you go onto the cornea, make sure you get the stem cells. Because again, the key here is not just taking the conjunctiva, but taking the conjunctiva right at the limbus. That's where the stem cells live. Those are the cells that are midway between conjunctival cells and corneal cells, and those are the precursor cells to normal epithelium. Epithelium goes centripetally from periphery to the center. So you want to take those cells right from the limbus and have them join here, and then you just transplant them into place. Remove the scar as best you can, and if you're really lucky, when the new cells grow in, the cornea will clear. If you're not really lucky, you just have to do a penetrating keratoplasty at another time. And there, that's me just gluing it into place. I'm just gluing the conjunctiva in using tissue glue. There's an activator and a precursor, and you put both of them on, and it stays on very nicely. I'm not going to talk about this much. I don't do this. This is Ed's slides, and this is cultivated limbal epithelial transplantation. You only have a little bit of cells. You take it, you culture it, and then you chop it up, and then you apply it almost like an amniotic membrane, and it regrows the epithelium, and it works pretty effectively in some patients. It's got limited survival, however, and we're still working the bugs out on this. If we could actually tissue culture the stem cells, you take just a few cells, grow them out for a couple weeks, and take those cells rather than having to take all the conjunctiva. But it hasn't been that effective yet, but it's occasionally very useful. And again, here are procedures that I do not do either. This is a Boston keratoprosthesis. Patients who have very damaged ocular surface with dry eye most commonly. Very commonly, these patients also have had stem cell damage where you can't repopulate the cornea, and you replace the cornea. Instead of using a natural cornea, you use an artificial cornea. This is designed out of Boston. It's called the Boston K-Pro, Klaus Dolman is the person who's been behind this, and he's still going strong now at the age of 90 and still doing remarkable work. If for really bad disease, you can use actually a tooth. You take the patient's canine tooth and then you drill a hole in it and you transplant it into the patient's eye, and this will not dry out. So patients with really, really dry eye, this is kind of the treatment of choice. And there's only about, I think, 5 or 10 doctors in the world who are doing this now, but it takes a whole surgical team to get this done. For patients who really have no vision, it can really be a godsend. So I've gone through a bunch of surgical options for dry eye disease, starting with the really simple things that are within the realm of most ophthalmologists, and if it's available to you, you can do that if you have range of practice. But simple things like cauterization of the punctum works so well. They can be done in the office, in the clinic, at the slit lamp, And then some things are done by comprehensive ophthalmologists. A lot of it's only done by corneal specialists, and a lot of it's only done by very, very esoteric corneal specialists who are really dedicated to helping these very unfortunate patients. And my hat's off to these people who do these procedures. Again, I don't do some of the procedures I just showed you, but they're very challenging. There's a lot of work that goes into them. And for patients who are really desperate, you can restore vision and really change people's lives in ways that you just thought were impossible just a few years ago. So that's my approach to surgical management of dry eye. Anyone have any questions for me about this? Okay, I baffled you with all that nonsense. Okay, yes?
With K-Pro, have you seen functional vision after K-Pros? Because in our practice, I'm not seeing many patients that actually get vision after.
Oh yeah, there's a lot of patients who get vision with K-Pros. The problem with K-Pros is they work really well until they stop working. And once they stop working, the eye's usually lost. The most common reason why K-Pros fail is that the patient develops end-stage glaucoma or endophthalmitis. But if they don't have those problems, they do well. What we've started to do is I refer my patients to Ed, who does them for me. And he sends them home on betadine drops twice a day, and antibiotic rotator on to prevent that. And we don't have good ways of monitoring their pressure because they don't have corneas. But in the very near future, we're going to have intraocular pressure sensors, which will be available in the next couple of years. We're working on that now for glaucoma. This will be a great place to put a pressure sensor inside the eye to document what the pressure is. So I've seen nice results, but the risk is high. This is a procedure that has a high risk of failure. When it fails, it's disastrous because there's no second chance. Great. Okay. But if at all possible, I'd love to put it in a scleral lens. The scleral lens would be my first-line therapy that I would do on these patients with irregular corneas. Okay, good. Yes?
Can you speak to artificial corneas and maybe where we're going there? Do you have any thoughts?
Yeah, they're working on artificial corneas now. They're certainly in the trial phase. To my knowledge, I don't know of any FDA trials that are going on right now in the United States. But an artificial cultured cornea would be good, taken from the patient's own stem cells. That would be a really exciting advance that would have no risk of rejection because it would be from the patient's stem cells. Hiroshita in Japan is doing tissue culture of endothelial cells. So you can actually, instead of doing transplantation, you can actually take the endothelial cells and mass produce them and then just inject them into the anterior chamber. They stick to the cornea. So there'll be no need for endothelial transplantation. That's coming along very quickly. That'll be entering trials in the United States very soon. I'll put a shout out to a company called CorneaGen that is a for-profit company that has developed a principle called venture philanthropy. I really love that term. And what that means is that they are a venture capital company that feels that not only do they want to make a profit, but they want to actually create a philanthropic advantage as well. And they're working with eye banks to develop better tissue models, better transplant models, and bringing some of these new devices that couldn't be done by eye banks because there's no structure to support them. And they're working very strongly. I think Liz is on the advisory board. I am as well. Ed Holland's in charge of the advisory board. And this is a company that's doing some great work on cornea that you'll be reading about in the very near future. And some ideas like artificial corneas will be what they want. And their goal is to eliminate corneal blindness by 2040. That's the goal of the company. All right, Omar, take over for me. Okay, good. Good.